Well, hello everyone, and welcome for another video or conversation on being polyvagal informed and how polyvagal theory can helps us in life. I'm quite excited today about our conversation. I have Dr. Heather Abernathy. I hope I pronounced your last name.
You did, yes.
Where we're going to be talking about polyvagal in medicine and in regards to physicians and medical students. So, which is quite, I think, in very new territory for the polyvagal theory to kind of influence, so to speak. So, Heather, how are you doing today?
I'm well. I'm really happy to talk with you.
Yes, we met at the TVI conference in was that November last year?
Last fall.
Was a really good friendship and relationship that I treasure coming out of that conference. So I'm double excited to talk to you today. So let's begin, Heather, from the beginning, and you could tell listeners more about your work and your journey and what led you to polyvagal theory and you doing this work.
Yeah, sure. Well, I'm an anesthesiologist. I've been an anesthesiologist for about 20 years, and I hear a lot from my patients. Two things. I hear them ask me, can you give me something to relax? That's a really big thing. And then also they tell me I don't want to feel anything. And so I hear these two things daily. And I started to really think about, what does that mean? What are my patients wanting? What are they asking from me? After I myself went through a journey of PTSD, and I suddenly realized that it's not only important for us to keep our patients safe, which we have incredible training in, and we have protocols and policies and drills to do that, but we have no training in how to help someone feel safe. And because of my own journey, I realized how important that was and what a gift that is for physicians to be able to give to their patients. And I found myself one day, I had to go to the doctor for just a routine screening. And this was during the time that was very traumatic for me. And I have lived in a hospital, like it's been my second home for like 30 years. And I found myself in the waiting room, kind of hunched over in like an almost fetal position, and found myself like rocking back and forth. And I thought, what on earth is going on? Like, this is ridiculous. What is wrong with you? This is like the place where you're the most comfortable. And so that got me thinking and learning more about trauma and the effects of trauma and how our body takes over without it asking for our permission. And so I started to learn about the polyvagal theory and how it applies to every area of life, but specifically looking at it with, how does this apply to healthcare, and how can we help our patients? How can we help their bodies to relax and to feel safe?
Yeah, I want to bring one thing you said, and I want to see if I am understanding the distinction between, keeping the patient safe from an anesthesiology, from a medical perspective, as their body is in a safe state, biologically, that they are safe. So when they're undergoing surgery, they have all the kind of the safe measures that would help them. And that was what you're taught and what you're taught to do. But you mentioned also feel safe. And that's, I think, what I understand is psychologically and kind of emotionally feeling safe.
Yes.
And that is not part of the learning process.
No, we talk about them separately, but they are connected.
Yes,
right?
Absolutely.
Because, yes. Right. If our bodies don't feel safe, we're not going to be in a state of health and vitality and healing. We're going to be in a defensive state, and going into surgery in a defensive state is not ideal. And there have been some studies showing that people at risk of developing chronic pain after surgery one of the highest risk factors is having a high sympathetic state going into surgery. And so if we can do something to help minimize that risk, it's to let our patients know that we'll take good care of them, that we hear them, we listen to them, we believe them, we trust them. And that we talk a lot about psychological safety and team building, things like that. But there isn't psychological safety without nervous system safety.
Yeah.
So how do we teach that?
Absolutely. So walk us through a day, at your work when you're, and you could say, you can describe it if you'd like before implementing those, principles of polyvagal theory and after. Let's start with the after. What does it look like from your job as a medical profession in a hospital where you're seeing patients who are going into surgery, which is it's never a fun thing for anyone, even if it's a very simple procedure.
Right.
The stress level is already, very high. So how does it look like in your day?
Yeah, well, I'll give a little example, if it's okay, of how it looked like
absolutely.
before and kind of how it looks like now that I use the tools that I've learned. How it looked before is, so I wake up very early in the morning. I wake up at 5 a.m. It's dark. I live where it's very cold, and my alarm goes off and I jump out of bed and I grab a cup of coffee and I rush out the door. And I get to work and I grab another cup of coffee, and I have to see probably 3 patients before 7 o'clock. And it is like you're on the clock, like the time is going nonstop. And I can walk into the room and a patient will just have so much anxiety that I feel it. It's like a wall of anxiety, and you can get kind of stuck in that. And where they have a lot of questions, they want to be reassured, but you don't have the time to sit and talk with them. And so it gets you I get more tense, more anxious, more worked up, and I need to go and I need to address other patients and other things. And once the day starts with patients going into the operating room, it just never ends. So I'm needing to see people before surgery. I'm needing to put them to sleep, wake them up, see them in the recovery room, talk to their families. I'm negotiating with surgeons on how we're going to do things. And this is multiple rooms, multiple patients throughout the day. I'm getting paged from nurses about questions for orders for it. You live in a sympathetic state. And there's times when I need to check out because it's too much. And I need to not notice what is going on. I can be on my feet working nonstop for 12 hours and I don't have time to eat. I don't have time to drink. I need to use a restroom. I'm tired. I'm all these things, and I need to not notice them just to keep going. So that's how things used to look.
And what happens at the end of the day?
Oh my goodness, at the end of the day. So I noticed that at work, right, you're just you're hyper vigilant, you're overthinking, you're overworking, you're reactive, you're angry. And at the end of a day, after that kind of day, I would come home to my family who would want to connect. And I just wanted to numb out, just wanted to withdraw, grab my glass of wine, grab my remote control, right, and just check out. So
and that's, I just want to add, that's a very normal nervous system adaptation, because you've been stuck in sympathetic for the whole day. And when it gets too much, then there's no energy left. So it switches to dorsal of that disconnect, leave me alone. I want to numb, like you mentioned already.
Absolutely.
It's a normal nervous system behavior, because it's helping us to survive what we're doing.
Right. I think that's why the polyvagal theory is so important, why it's so, why it's critical to get it into healthcare, is that it normalizes being human.
Yes.
It takes the shame out of being human. That once I started to understand how our nervous system works and fluctuates and our different autonomic states, what I started to say instead of what's wrong with me is, of course that's what I would do.
Yeah.
Of course I would do this because my body is overwhelmed and it's not going to run out of here. I'm not going to fight the healthcare worker. I'm going to just withdraw and protect myself.
Yeah.
And it makes so much sense.
Okay. So with the polyvagal principles and how we really understands our nervous system, what shifts happened to your day and how is it looking like now?
Yeah, it looks a lot different. It's not like my day's perfect. Like I don't have any stressors, right? And that
No.
it's just this amazing floaty kind of happy day. It's not like that. But what I do is I bring an awareness multiple times throughout the day. I bring an awareness to what is my state? What state am I in? And that was just built slowly over time of how do I check in and check my state? And there's different things you can do. Sometimes at the beginning, just set your phone for twice a day for your alarm to go off. And when it goes off, just kind of scan, okay, what state am I in? Yeah. And then just recognizing that. So now it's almost a repetitive question.
An automatic thing that happens.
Yeah.
Oh, I'm sensing a tension in my shoulder, and it's like, yeah, something is happening. So, and then I would kind of notice and know what it is, and then go on. If I need to, I will shift that.
Yes.
And I'll take care of myself.
Yes, absolutely. So doing that throughout the day of where am I? What do I need? And sometimes it's, well, I'm in a sympathetic state. Well, what do I need? Well, I actually need to stay here for a bit longer because I have things to do, and that's okay. And or maybe it just changes. I'm in a sympathetic state. So, and I need to stay here for a little bit longer, but instead of, getting irritated with someone, I have a few seconds that I'm just going to go walk a loop around and help move that energy a little bit. And I'm checking in and I'm seeing, what do I have? What resources, what tools do I have? What do I need to get me back into a social engagement ventral vagal state? Even if it is 5 seconds, 3 seconds, right? It's that kind of taking that opportunity to ground myself whenever I can. And a lot of times that's when I'm talking to my patients as that time. Yeah. So before I go into a patient room, if I can take one breath, kind of sense where the energy is in my body. And if it's an anxious energy or a defensive energy, I find my feet, I find my body in the present moment. And I set an intention quickly of what's the word that I want to carry into the room with me. And whether it's calm, connected, curious, centered, compassionate, right? All those C's of the self. Yeah,
because patients, every person we meet sense that. And if I think I would, as a patient, if my doctor, my physician, whoever is coming in, and I feel that calmness in them, or at least that reassures me. But if I find them anxious, and I've met doctors who are anxious and they just want to rush, and I feel like, why am I here? There's no point why I'm here. So it's that patients do feel that, sense your nervous system. And then one thing that you said is really important. It's not that we want to be happy and calm and cheerful all the time, because life is not like that. And our nervous system needs to have that flexibility of going in and out. For anyone in the helping profession, physicians, therapists, even parents, sometimes you just have to override what is happening, something that's worrying happening at home, something anxious happening, bad news happens and you're seeing a patient, or you're picking up your kids or something. You have to override that in order, because you have a responsibility for that other person. And we do that all the time. but without awareness. But when we are aware that, first of all, okay, I need to have that because that's my responsibility. I want to give them that, create that sense of safety where you're talking about. So what I need to do now to kind of bring me back in with a little bit of ventral. But after, when I have the time, I could really go and really take care of myself and see what do I need.
Yes. Yes, you're exactly right. Because if something happens in the operating room, right, I need to mobilize. I need to address it. I need to act. I need to not shut down, right? But when it's over, I need to find my way back to calm, or I just get stuck in that state, right? My allostatic load builds and builds and builds until my new state is living in a defensive state.
Yeah. So how do we help someone feel safe? And especially as a physician, if there's something that you want everyone in the medical field to know, like where do we start with that?
There's two parts to that. One is having an awareness ourselves of our own state. And how I think about that is I think about the ABCs, and I think A is for awareness. So again, just building this awareness of your own autonomic state. B is breathing, learning to take a breath or two and having that really long exhale. I think about exhaling through a straw, a long exhale, and that will activate our parasympathetic nervous system, our vagus nerve. And then the C is self-compassion. And it's the work of Kristen Neff. And self-compassion is made of three things. It's mindfulness. So again, an awareness and understanding of, oh, this is where I am. It's kindness. So again, building this habit of recognizing how you speak to yourself. And I would never talk to you the way that I talk to myself.
Yeah.
And so
Absolutely.
Starting to talk to yourself the way you would talk to your friend.
Yeah.
And then the third part of self-compassion is common humanity, recognizing that I'm not the only physician who has felt this way. I'm not the only woman who has felt this way. I'm not the only, right? There are people across the world right now who feel the same way that I do. And so starting with ourselves, and then we need to do that in order to help our patients feel safe, because we can't sit with someone who's dysregulated and be helpful if we're dysregulated. So once, and that's not something you just learn and you got it and it's done, right? It's a practice. It's a lifetime journey. And once we start working on that and are building that practice, then I use ACLS. ACLS is Advanced Cardiac Life Support. So it's something that all healthcare providers are familiar with, ACLS. And ACLS is how we can think about things to do to help our patients feel safe, their autonomic nervous system to feel safe in the moment. And A is, again, awareness, because that's where everything starts. So having an awareness, building the skills of just getting an idea of what state is my patient in, right? Are they calm and connected? Are they in ventral vagal? Are they in sympathetic, or are they in dorsal? And so I talk to physicians about what are different cues we could get from our patients to tell us, give us a hint of what state they may be in. So an awareness. And then C is choices, giving our patients choices, as many choices as we can give them, because that's going to help them feel like they have some control and that they're safe and they're a part of the team. And that's really empowerment, recognizing that our patients are experts in themselves and we aren't. And working together to build that connection is going to help them feel safe. So awareness, choices. L is listening, because we as healthcare providers are really poor listeners. We like to interrupt. We have an agenda. We need to get things done. We need to move on to the next person. So as you were saying, when you've had physicians who come in and they're anxious or they're in a rush, you don't even want to share with them.
Yeah, absolutely.
You sense that like they're not listening to you.
Yeah.
So building those skills of listening and active listening. And I think I think a really good way to start building the skill is, can you ask just one more question? Just one more, like start to build that skill. So for example, as an anesthesiologist, people tell me again all the time, I need you to know that I'm just really nervous.
Mm-hmm.
And I could and used to say, oh, it's okay, don't worry, we'll take good care of you, and like move on.
Mm-hmm.
But now I ask, what are you most nervous about? Because it's amazing. Sometimes people are nervous about, like, they're having surgery and they have cancer and they're afraid they're not going to get it all. Or they're terrified about losing control under general anesthesia. Or their fear is, no one's going to treat my pain after I wake up. So what I learn about that can change the plan of what I do. And it lets the person know, like, I'm really interested in you. I want to hear your fears and concerns. And then S is two things of ACLS. It's to go slow, or at least to have the sense of going slow. Even if you can't go slow, you can actually have
A sense of slow. Yeah.
a sense of slow, an energy. Sit down. Like, don't stand while you talk with another person, a patient. Sit down, be on the same level.
Mm-hmm.
And that brings a sense of, I'm not in a hurry. There's no urgency to this.
Mm-hmm.
And then sensations. So I try, again, if people before surgery are really nervous, I do things to help them to bring about their sensations. So I'll have them ask them if they have a pet, and do they want to show me a picture of their pet?
Yeah.
And then they look at it, or their child, or something that they care about. We have these like squeezy balls, stress squeezy balls. So I can get them one of those. I get a warm blanket. If, ask them if they want
Resources.
that.
You're giving them
Resources, right? Do they want to turn on their music from their, whatever device they have with them? And just, again, giving them choices and bringing in sensations to bring them into the present moment. And I let them know, like, you don't have to be in this bed the whole time. Like, if we're not ready to go, you can get in a chair, walk around. Like, you don't have to be immobilized in this bed. Nobody else here is laying in a bed,
Yeah,
So,
I think that one more question is such a beautiful prompt, because just with the example that you gave, it's like, oh, I listen to you. I hear what you're saying, and I want to know more. So even if it would take a few seconds more, and I think it's also, we could be quick in a sympathetic
yes.
survival, and we can be quick with sympathetic, but with ventral as well. And it's just a mind shift, bringing in more resources that we can do things. And what you were saying is so beautiful. And I have the sense, I'm not a medical profession, but I've been to hospital, I've met doctors, I've met, many people I know are patients. That's not the reality. No. And I don't think we have enough time to know how we got there, but it's a culture of stress, a culture of, hierarchy. Physician knows better. Patient, you just need to follow what you're being told. And if ask many questions, that's just, that's a difficult patient.
Right.
So how does, is there, the shift would be quite slow.
It's a paradigm shift, right? And paradigms take a long time to shift.
Yes.
It's the slow work of just one person at a time.
Yeah. And I think that's why, I know Dr. Porges is very keen and passionate about bringing it into medicine. And if we want to go from the beginning of, medical students, and how I've obviously never been one, but I know a lot that it's very high stress. They're, barely any chance to breathe. There's competition and, striving, going nonstop.
Mhm.
And I
Yeah.
know, like you said, it's a paradigm shift. We cannot shift that. But how, as a medical student, how they could support themselves. And for anyone listening in the academic world of medicine, and I know this is part of the work that you're doing, what would be helpful to know for students and academics as well?
I think what we've been talking about, the polyvagal theory, getting that information to them as
Mhm.
part of the core curriculum from the very beginning is so important.
Mhm.
Just to let them know that this is what our bodies do, and this is understandable, and be aware of this, watch out for this. I think just giving them the knowledge, even if they were given the knowledge of like, this is what your patients may experience,
Mhm.
just having that, they are better equipped
Mhm.
to recognize that in themselves. But I think if you can go even further, and as medical schools themselves, it's helpful for them because medical students aren't going to learn very well if they're in a defensive state.
Yes.
So if they're overwhelmed, and everything you said is exactly right, there's an incredible amount of knowledge that they need to take in.
Mhm.
There are very long hours. There's little sleep. They're constantly being evaluated and tested on how good they are. Do they stack up?
Mhm.
And there's a whole set of unwritten rules in medicine that people don't tell you about, but you've got to figure them out. And when you don't figure them out, people are right there to tell you that you didn't do something correctly.
Yeah.
And so letting the medical students know that their bodies are going to, their nervous systems are going to do all these different things is helpful for them to learn and to take in more information and to become better physicians by becoming more informed humans.
Yeah. One of the gifts I got from polyvagal theory, and that probably I've sensed it in one way or another, but now I know it for sure, is that you mentioned it, evaluation. And Steve said, evaluation is a threat response. That's our nervous system sense it as a threat response. And that it's when I'm with someone socially or in any setting, and I feel that they're evaluating me and I need to kind of pass the test, whether it's what I'm saying, what I'm looking, what I'm wearing, and any of those things, I don't feel safe and I feel very on the edge. So just knowing that setting of evaluation is a threat response.
Right.
And it's how we can manage it, how we can find our resources, not necessarily because, of course, every medical student has to be evaluated. We're not,
Right.
exams need to happen, stress will happen.
Yes.
It's just bringing awareness that, and that's, I think, the most important thing, to bring awareness to it. How can I do it better? Equip myself. And I give the example of simple as, if you look out the window, you see it's raining, you either going to get an umbrella or wear a rain jacket.
Mm-hmm.
That's a fact. You're not going to go outside and get wet and say, oh, why didn't it stop raining? That's not, and that's the same thing.
Yes.
That happens.
Yes. And I think that's part of why it's so important to recognize what state you're in and what your body needs. What is it telling you? What does it need? Because what that does is it allows you to have more choices.
Yeah.
Right.
Yes.
And you can make an informed choice.
Yes. Speaking about evaluation, and because that sense of threat is beyond our awareness. And that's also one of the key things in principles in polyvagal theory, which is neuroception, which is a term coined by Dr. Porges. And it, again, like you mentioned earlier, what I why I feel passionate and I love the polyvagal theory, because I really can sense it. It's not something that I'm only understanding as in my brain and understanding the science of it. No, I sense that in my daily life, in how I relate to things, where we sometimes, for no conscious reason or rational reason, we want to say, we feel that sense of threat. There is something I not, and probably we don't put the word scared or afraid, but we have that uneasy feeling.
Yes.
And when understanding neuroception is valuable, to know that, to acknowledge and validate, oh, this is happening.
Right.
And I know you want to speak more about neuroception and the importance of that in medicine.
Yeah, I think
Maybe we could first define it as well. So if anyone is not that familiar with the polyvagal theory, we'll get what we mean by neuroception.
neuroception, it's how our body on a subconscious level takes in all this information from around us, our environment around us, from inside of us. So interoception, what are the signals that are coming from inside our body? And then also between us. So on a nervous system level, are we resonating? Is there an energy, or is there kind of like a block or mismatch? And so we take in all that information and we kind of sift it, and we it puts us into an autonomic state. One of, either safety, ventral vagal, or one of the defensive states. And it happens without our participating in it. And so I think about, again, patients coming into the hospital. This is a foreign environment for them. I mean, things look different. There are just cues of threat everywhere. Everywhere. From the minute they walk in, I think it's a sense of losing control, losing autonomy, losing choices, right? And then coming in for surgery is even more extreme. Because you are losing control. And so all these things are going on for people. And then the importance of recognizing the history that they bring with them, their nervous system history when they come into a hospital, right? Do they have a history of trauma? Because that's going to come with them.
Yes.
There's going to be a memory, right? Our body keeps the score. And so times when I've been talking to patients and we're talking about something, I spoke with this woman who was in her 70s, and we were talking about her surgery, and she, what seemed like out of nowhere, started shaking and started crying and then couldn't catch her breath. And it had to do with when she was in her 20s having a C-section and all the things that happened that she had thought she had forgotten about.
Yes. The body doesn't forget.
No. And just holding space for that and recognizing that that is a thing. I think in medicine, we as physicians are so quick to say that's not a thing. That's not a thing. Because we don't understand it. It can't be an actual physiologic response. But it is. So neuroception is really important, and it shows how important we are as providers to foster a space of safety and connection.
Absolutely. And I'm thinking, when you were talking about medical student, I don't understand how anyone goes into medicine. I'm just grateful that people go into medicine, because we need physicians and we need, people learning that thing. But it just, I don't understand how anyone decides to go through that grueling years of study, and and I think they deserve, a lot more support and
Definitely,
a lot more compassion.
They definitely do. And people enter medical school with the same kind of mental health as their peers, but after just 2 years of medical school, their rates of anxiety, depression, burnout even are like 3 times that of their peers. and the rate of suicide is increased, and that doesn't decrease once you become a doctor. It actually goes up. So again, there's this whole culture of trauma, the trauma of medical training, which is not being addressed.
Okay.
Because
Can you
again,
say
that
more
would
about that?
I think that there is so much shame in medicine, in the training of medicine. It's, like you said, it's grueling to get in. And once you're in medical school, it's this hierarchy. I mean, I can tell in the operating room when I walk in, and if there's a medical student and like from the surgical team, I'll know right away, because I walk in and they're like, "Oh, sorry." And I'm like, "What are you sorry for? Like, you're just standing there." It's like, "Sorry." Like, you have to apologize for just being there, for being in the way. And yet you need to make yourself known, because to get to the next level, you need to have people be aware of you, but not get in anyone's way, not be obnoxious. You need to ask questions to show that you're interested. Otherwise, they're like, "Oh, this person has no interest. We're going to give them a bad evaluation." But if you ask too many questions, well, then you're obnoxious and nobody wants to work with you. And it's this constant trying to navigate what is good enough. And yet, there's these terms that we use in medicine, like be a wall. Everyone knows what be a wall means. If you're a doctor, you know what that means. And what that means is when you are the person in charge, the person on call, you usually have a backup person. Someone, if things get really out of control or you need help, you can call them. But I've had it said to me so many times, when that person's leaving and they look at you and they say, "Be a wall." And what that means is, don't let anything through. Don't call me. You can handle it.
Okay.
Don't be a blocker to me. You don't need me. And there's a shame in needing help.
Okay.
As a resident, I had a staff and attending who would always say to me, "Don't make me get up. Don't make me get up." And so if you needed help, you were going to do everything possible to not have to call for help. And what are we teaching our medical students, our residents? Yeah. So a common word to describe a resident, a medical student, is weak. They're either like, "Oh, they're pretty weak."
And that I'm guessing that if they show emotion, or if they can't handle stress or any of that, which is a normal human response.
Yes. All of those things. Yeah. And, you need to be able to perform at your highest when you're sleep deprived and haven't eaten, and you need to be on, and you need to know how to do this. And if you're not, then, that person's kind of weak, or they're a strong resident. And those are the words that are used. And we're expected to not have emotions, not be in touch with our emotions, not notice, yet we're expected to be human with our patients.
It sounds like a lot of a mixture of, be sympathetic but dorsal, only in social engagement, engage on demand. It sounds like a complicated spaces to be.
Yeah, I think that's a good way to describe it.
Yeah, like a freeze, you're functionally frozen, because you have to be in dorsal and shut down and numb, but you have to mobilize at the same time. It's such a very difficult place to be. And it's just heartbreaking to know that this is the system that is in charge of health care.
Yes.
But you're not supposed to care for yourself.
Right. Right. There's very little room for that. Yet we hear a lot about resilience. And I think, what we hear about it, unfortunately, is, well, you need to go to yoga more, or you need to breathe more. You need to do all these things for yourself without addressing really the culture of it.
Mhm.
And it puts the onus on the individual. Like, again, you're not strong enough to be able to handle this. And that's just not true.
Yeah, it
And
needs it because it's really stressful to be trying to do things differently when you're in a system that does not allow for that. But with hope that maybe one physician at a time, one academic at a time, which I'm noticing we're coming to the end, and I don't know how time just just flew by. Is what really about your work now? What are you doing? And I know you have this course on PVI, the Polyvagal Institute.
yeah,
How your work looks like in reality, in day to day, in your work, whether in the hospitals, universities, or in anything.
well, I love to speak with physicians
Mhm.
about this, about nervous system regulation and interoception and the culture that we're fostering. And so I have done that around the country, and I hope to continue to do that. I also am starting to give workshops
Mhm.
on how does this look? How do we put this into practice, right? It's so foreign that how does it look to notice our state?
Yes.
What are some tools to use to shift our state? So helping embody
Yes.
what it is that I'm talking about.
That's great, because still medicine is a hierarchical and field, and even in society the medical doctor is still revered as know-it-all. They know everything, and yeah, and we need physician to speak to them, because I'm sure even if that I don't know if Dr. Porges can get through to them, because he's not a physician. He might not know, to them enough. But I think it's really important coming from physicians on speaking up and seeing how we can do. And I'm sure I've met a lot of really good physicians, and ones that would take time and look and smile and say, oh, how are you today? And so there are good, amazing physician. I don't want to also paint a
Many,
whole horrible picture. And
no,
people like you who are physicians and trying to do things better, unfortunately, you had to go through a lot of distress to find that out. But we need more physicians. I'm losing my my words. But so how do people get in touch with you, Heather?
they can go on the PVI website. So the Polyvagal Institute website has courses, and you can find my course there. I'm on Instagram at Dr. Heather Abernathy, and you can always email me also, heather@drheatherabernathy.com. I would love to talk with anyone. And I do want to say that every single time I have presented this information, I have spoken to physicians, the reception has been overwhelmingly positive. And so doctors are hungry to hear this and to have some tools to help themselves to feel better, to tune into their bodies, to better attune to their patients.
Yeah, I think it because it speaks to the human condition.
Yes.
Beyond background, race, culture, all of these things that we like to put that differentiate people, but it's the same. Everyone has that nervous system, and it's simple, but it's not easy, but it's very intuitive. Like, oh, resources, what resources we can. I have these flowers are part of my resources. My desk has a lot of resources. My window,
Right.
looking up the sky is a resource, and it is simple that it could be the simplest things that could take us to ventral and get us a sense of safety. It's just not easy to implement right away, and it needs practice.
Yeah.
And the amazing thing that I love about this work is that the nervous system reshapes itself. There are it does change, and it makes things better in my experience, and from your experiences as well. Well, Heather, it's been a pleasure speaking
Thank
to you,
you.
and I really,
too.
really hope this kind of trickles to many physicians all over, and we could find, more compassionate medical system and hospitals and physicians and universities. So yeah, thanks a lot for your time
Thank
and for
you.
your work.
Thank you very much.
Yeah.